Well, welcome everybody. I'd like to start with our webinar today to highlight our new targeted issue grantees. We have 6 excited grantees for the next 3 years that will be focusing on pre-hospital care, so we are very excited to have them as part of our EMS for Children's portfolio. My name is Beth Edgerton, and I'm at Maternal Child Health Bureau at HRSA, and I also have Diane Pilkey here, who is the project officer for the targeted issue grants. And again, I thank you for joining us today and being part of this webinar. I'd like to introduce who our presenters will be. We may be changing the order a little bit just because you all are busy individuals and with many conflicts, so I realize it's a challenge. So I appreciate everyone's flexibility as we may change the order. We have Dr. Brooke Lerner from the Medical College of Wisconsin, Dr. Scott Rohde from the Gesell School of Medicine and the Dartmouth Hitchcock Medical Center, Dr. Robert Silverman from the Hofstra North Shore School of Medicine, Dr. Andrew Stevens from the Indiana School of Medicine, Dr. Manish Shah from Baylor College of Medicine, and Dr. Mary Fowlett from the University of Louisville Research Foundation. So to those of you that are new to the EMS for Children's program, we have what's called our Targeted Issues Grant Portfolio. And these have always been grant opportunities that have provided us the ability to fund innovative studies, things that are cross-cutting in their approach that can be applied in multiple venues, and really address gaps. And one gap that has been a recurring theme for EMS for Children has been pre-hospital research and knowledge on the best systems of care. So this year, for the first time, we were able to invest $5.4 million over the next 3 years on these 6 new demonstration projects. And again, we're excited because it's the first time the program has had a concerted effort to focus on specific care in the pre-hospital setting. We've dabbled that in the past with many of our previous targeted issues, but we haven't had one time where the whole focus of this grant announcement has been about pre-hospital care. And so that's where we're bringing all of these topics together today to give you a snapshot to see where the program's going and where the opportunities in the future in our knowledge is in these areas. We had 2 different focuses. One was on the focus of the feasibility of pre-hospital research, was developing an EMS pediatric research network, which we'll hear about from Dr. Brooke Lerner. And then the other grantees are looking at components of care in the pre-hospital setting to include clinical delivery, training, and operational systems. So I'd like to start first with Dr. Brooke Lerner from Medical College of Wisconsin. And Brooke, I'll let you sign on, and if you could just say next, and I'll advance your slides. Thank you.
Okay, thank you. You can go ahead next. Oh, these look terrible, so I'll just apologize. So this is the Charlotte, Houston, and Milwaukee Prehospital EMS Research Node is the name of our grant. Next. So basically, this is intended to be an EMS node of PCARN, and the way that we've developed it is that we have 3 EMS affiliates. They're Houston Fire Department, Milwaukee EMS, and Mecklenburg EMS. At each of these sites, the EMS agency has agreed to participate in this research network. It's led by a site PI who has an association with the agency, a local academic advisor who has research experience, and then a field provider advisory group, which consists of 5 local EMS providers who are interested in research and able to give advice to our node as we embark on EMS research. And the whole goal is that as we work through developing research projects, they be relevant to EMS, innovative, and feasible in the EMS setting. Next slide. To give you an idea of the population that the node will serve, our population is almost 4 million. And we see about 25,000 pediatric calls within the 3 systems each year. All of the EMS systems have a highest level of care at ALS and represent about 1,034 paramedics. Next. In terms of research elements, all of these sites have prior research experience, including having conducted randomized clinical trials. all sites maintain a medical record database, and these databases are all NEMSIS compliant. They all have experienced field providers on their advisory committee, so they've all identified 5 people and actually met several times. And each of these agencies has an IRB of record, and each of those IRBs has provided us with a letter stating that they are able and willing to review emergency exception from informed consent trials. And in fact, 2 of the 3 agencies have done emergency exception from informed consent. Next slide. In terms of structure, so our node is fairly lean. I'm the nodal investigator, and Brittany Farrell is our nodal administrator. Next slide. And what our agencies look like is Mecklenburg. These are an all ALS response agency. It's actually municipal, but it's run by both the county as well as the 2 healthcare systems within the region. So it's basically a public-private partnership. They take about 87,000 calls a year. 15% are children, and 9 operate paramedic receiving hospitals. Next slide. Their site PI is John Studnick. He works for Medic as their quality improvement manager and also is an active EMS field provider. So he takes calls a few times a month. He's the director of Prehospital Research at Carolinas Medical Center and has a doctorate in epidemiology. In fact, I think he was the first National Registry of EMTs fellowship, first people to complete the National Registry of EMTs fellowship. He has over 30 peer-reviewed EMS publications, and he's completed 2 pre-hospital randomized clinical trials. Next slide. Houston Fire Department is our second affiliate agency. This is a 2-tiered fire-based system. There's over 3,500 providers, and they're all trained as EMT firefighters. They take about 22,000 calls per year. 14% are children. And the majority of the pediatric patients there get transported to 1 of 2 children's hospitals. Next slide. Manish Shah, who also is an additional targeted issues grantee that you'll be hearing from later, is their site PI. He's the director of research education at Baylor. He's also the director of the Texas EMSC State Partnership, and he has the current targeted issues grant as well as a prior one. He's the chair of the EMS subcommittee for AAP, and he's been contributing to the revision of the National Pediatric Prehospital Performance Measures. Next slide. Milwaukee County is the 3rd quote-unquote agency that's part of our partnership. Milwaukee is interesting in that it has 12 municipal fire departments. However, these fire departments come together under common protocols and a common medical director, and they have some common research committees so that working within Milwaukee County, you work with the 12 fire departments, but you don't have to go through 12 different systems for approval. They have about 40,000 calls per year. Approximately 10% of those are for children. They transport to 15 affiliated paramedic receiving hospitals, but all of those hospitals participate in a research consortium and so are willing to have hospital outcome data for studies obtained from their facilities, and there's processes in place for streamlining IRB and things like that. Next slide. In Milwaukee, the PI is the site PI is Lauren Brown. He is the pediatric medical director for Milwaukee County EMS. He's board certified in both pediatrics and pediatric emergency medicine. And his previous research includes assessment of pediatric motor vehicle crash injuries and use of CT to identify cervical spine injuries. Next slide. So that's great. That's what we are. And now what are we going to do with all of this? Next slide. So our aim 1 is to establish an infrastructure. So to do that, we've developed a steering committee that it consists of each of the site PIs, the academic advisor, and the chair of the field advisory committee. And then each of the field advisory committees locally meet. And so that way there's a local infrastructure as well as sort of a node-wide infrastructure. And what they do is work to develop projects together, basically ensuring at each step they're relevant and feasible to EMS. And so I think the difference between sort of things that have been attempted in the past is that we're going to try to involve local field providers in each step of a project development so that we're sure the project that we develop is capable of being instituted in the field. We're using Google Sites for sort of an internal communication infrastructure, and then also to make sure people know that we're available and looking for research to conduct. We are developing an external communication infrastructure, which includes a public website and then our Facebook page. I encourage anybody to like us on Facebook. And then we're also working to integrate with PCARN's infrastructure. Since this is a different setup from the other nodes, and yet we can all work together and use our strengths to conduct good research. Primarily, we'll work with PCARN for scientific feedback on our proposals, as well as the ability to expand sites as we get going. Next slide. The second aim of our project is to develop research concepts. So we want to develop and champion relevant and significant research proposals that are related to pre-hospital care of children. And so we're working with the sites to develop lists of research ideas. And so at the site level, they're developing lists of possible study ideas. Into all three steering committees will vote on those ideas to prove them as being both relevant and feasible. And those that sort of rise to the top will be selected to develop into concept papers. Once the concept papers are written, they'll again be distributed throughout our 3 nodes for review and approval. Once that approval is received and we're sure they're relevant and feasible, we'll send them to PCARN, who will provide feedback on the science. And then once that information is received, it'll be sent back to the investigator to kind of go on to the next step, which would be to develop a complete protocol. And that'll follow the same cycle. Once that cycle is complete, then the investigator should have a very good proposal for being able to develop a grant proposal. Next slide. Next slide. Along with that, because many, as you probably know from the IOM report and other things, there's a limited number of EMS researchers with EMS research experience. And so to try to kind of help develop our research resources, we're using both our academic advisors and PIs to act as mentors as research projects come through. And we're also working on developing a lecture series on how to do research. So far we have 1 lecture up, which is about ethics in EMS research. So far that lecture's had 100 views, although I haven't looked in a while, it may be more. Next slide. And actually there's, I think, 8 lectures that will get into the series and be putting them up periodically. The third aim of the project is to complete a pilot project. The intention of this is to basically demonstrate the ability of the network to collect data and to help people who start, who are developing a grant proposal with developing sort of the pre-work that they need to present in a competitive grant application. So to do this, we'll develop a protocol. Right now we're at the concept stage, which we've just had reviewed by PCARN, and we'll be taking that information and using it with the feedback from our advisors to develop a full protocol. We'll be getting approval from the IRBs and also working with the local hospitals to collect their outcome data to show that we can link between the EMS and the outcome data. We'll take that together and be able to collect and analyze that data. And I think that the objectives that we've developed are compelling enough that information will have value outside of just grant applications, but of being able to disseminate within peer-reviewed journals and other sources. Next slide. And then our final aim for the funding is to obtain funding for a larger project to develop and submit a fundable proposal to conduct a relevant and innovative pre-hospital research study. And basically, the aims 1, 2, and 3 should lay the groundwork for this so that at the end of the grant cycle, we would have a well-developed application. Next slide. And so that's what our project is, and I'd be happy to answer any questions if you want.
Again, if anyone has questions for Dr. Lerner, there's either you can unmute your phone, or also there's a chat box in the right bottom corner if you want to submit questions. Thank you, Brooke. I really appreciate you laying the foundation of all the nuances that go into establishing a EMS research network, and we look forward to the products that come out of this, and also just a better understanding of what kind of services are provided and what the gaps are for pediatric pre-hospital care. If there are no questions, I'm going to move on to our next speaker, Dr. Scott Rohde.
I had raised my hand. This is Lenora.
Oh, I'm sorry. Lenora, please.
Hey, Brooke, good morning. I was thinking about the aim, I think when you talked about developing research lectures for folks, who's the audience for those lectures?
Sure. The intended audience, there was a big emphasis on working within the agencies, so it's really providers, although we've put them up on YouTube and anyone can watch them. Basically, it's you know, the beginning researcher who's interested in EMS research.
Great. Maybe I can talk with you offline, because we get that request from some of our project managers and when we run workshops for NEADARC. So I'd like to see what you're planning, so I might want to have people go there and take a look at some of those too. So I'll just try to catch you offline on that.
Oh, okay. Thanks.
Any other questions? Great. Dr. Scott Rohde and his team, I'll let you guys start.
Okay, good morning. You can move on to the next slide. Nobody needs to look at that. Thank you. So our project is innovating and improving pre-hospital pediatric care in rural New Hampshire and Vermont, and CREST Network for Emergency Medical Services. Next slide, please. Actually, you go back to that just for 1 second. So I'm the PI. Tom Trimarco is one of our faculty, is also EMS fellowship trained out of Cincinnati, and although I am the PI, he actually will be doing a great deal of the work on this project and will actually conduct part of this presentation. I'll just give a brief intro and overview, and then I'll hand over to Tom. Next slide, please. So the CREST network is something that I developed 6 or 7 years ago. The idea was to try to support, we're in a relatively, I think probably uniquely for this group, rural area. We have something like 2 million residents, over 16,000 square miles or something between New Hampshire and Vermont. And it's fairly mountainous terrain. We have lousy weather. And so there are a lot of pretty isolated providers, both pre-hospital and hospital-based. CREST was developed to address the problem for hospital-based providers, and to try to support both educational initiatives, research, and more operational issues. The emphasis really has turned out to be mostly on education. And so the relevance of this to the current project is that as part of the current project that we're now discussing, we are going to create a network that is similar in nature to the CREST network that already exists. Obviously, though, aimed at pre-hospital providers, but we'll rely on a lot of the same the same relationships, some similar templated documents with respect to formalizing the network and so on. And I think that's all that I need. Was going to that's just by way of background, and then Tom will talk about the actual deliverables on this project beyond the establishment of the network.
So, good morning, everybody. Next slide, please. So since it seems like a fair amount of the other grantees are from urban areas, as well as obviously the majority of the population across the United States, we're just going to mention quickly the challenges for pediatric pre-hospital care, and specifically why this becomes the focus of our grant here. So I won't go into depth regarding the pediatric challenges. Obviously, everybody that's involved in this phone call knows the unique challenges regarding the pediatric patient population, specifically in the pre-hospital realm, the limited initial and continuing education opportunities for pre-hospital providers dealing with pediatric emergencies, and by just default, the nature of the business being high-risk and low-frequency events for these PD emergencies, pre-hospitally and in the emergency department. Next slide. But specifically, we do face a fair amount of specific challenges up here due to the rural environment. EMS agencies and emergency departments up here as well are very much scattered throughout a significant geographic distribution. This causes multiple different barriers when it comes to transportation issues for EMS services. So certainly the travel distances for EMS providers up here are much larger, both to the patient as well as to the receiving facility. You take into account the longer travel distances with harsh weather, poor road conditions, and a multitude of other issues. And you can see that the pre-hospital time for pediatric patients in this area can become quite large. There's also significant delay in just EMS activation as well, again, increasing the pre-hospital time for these pediatric patients and the time in contact with pre-hospital providers up here. And even if once they get transferred to the receiving facility, oftentimes there's an interfacility transport that is the next logical step with the multitude of critical access hospitals across the 2 states. Usually for a sick pediatric patient, that critical access hospital is not the end point. They will be transferred to one of really 3 receiving facilities across Vermont, New Hampshire, and even Maine, and these patients ultimately end up back in the pre-hospital realm, going in between institutions. Given the rural area as well, there's a significant amount of communication barriers. Unfortunately, our topographic features up here, as well as the long distances between population centers, make it quite a difficult area to get good cell service, get good cell coverage, and even radio transmission with crews. So one of the major things that we like to provide to our EMS providers in terms of medical control and online access to emergency physicians is often compromised because of these issues and communication barriers. Like all agencies and EMS agencies, there are multiple educational barriers as well. Obviously, there are a lot of high-quality courses existing out there, the PEP course, the PALS course, but given the nature of EMS, where a large majority of the EMS services in the Vermont and New Hampshire area are low budget. If anything, they are volunteer, very few career departments. The funding available to access these educational opportunities for providers, specifically for pediatric emergencies, is quite limited. Providers also often need to travel significant distances to access these courses, which are not being held at the critical access hospitals or at their stations, typically at the larger tertiary care facilities, which there is really just one in both states of Vermont and New Hampshire. And while online education has really started to increase and allow for some asynchronous learning for these EMS providers in more rural areas, again, communication barriers that are complicated by the lack of high-speed internet access and good 3G or 4G cell service limits the availability of these online educational opportunities as well. Medical direction in New Hampshire and Vermont is quite different than the vast majority of the country. In New Hampshire, the setup is such that agencies are required to have a medical resource hospital, and the EMS medical director, which I am here at Dartmouth-Hitchcock, fills the role as medical director for the agencies somewhat by default. In Vermont, the state is separated into 13 districts, and there is a assigned district medical advisor, which I also function for District 9 in Vermont. And again, all of the agencies that fall within that district fall under the medical direction of that medical director. Unfortunately, not unlike much of the country, there are very few medical directors, both in New Hampshire and Vermont, that are emergency medicine trained. Certainly, there are none that I know of that are pediatric emergency medicine trained up here, and even less that have any formal training on medical direction or EMS fellowship. The way this system is set up as well is there's very little, if any, compensation between the hospitals and the medical directors that are providing the services to these agencies. again, limiting the amount of time that a medical director has to work on QA and QI, to work on educational opportunities, to work on competency assessment, and that certainly gets us to our next bullet point. Myself, as medical director, am responsible for hundreds of providers across these 2 states, and my ability to really do a good competency assessment on the individual provider is very much limited because of the difficulties I just mentioned. Next slide, please. So our aims in this project are to really take the CREST model that Dr. Rohde has developed over the last 5 or 6 years and extend it towards the EMS environment. So we look to extend the quality improvement and the competency assessment resources from the CREST network infrastructure to EMS services in the area. We're looking to develop 2 toolkits, one for education and knowledge and skills acquisition, and one for competency assessment that can be utilized throughout the process and for all educational endeavors going forward, not only pediatric, pre-hospital stuff. And then we look to improve the communication and the relationships between the in-hospital providers and the pre-hospital providers. Next slide, please. So the first goal of the project really is to establish the CREST for EMS network. This is going to be done in several ways. We're working with 2 other medical resource hospitals closely, New London Hospital and Cheshire Keene Medical Center, which is associated with Dartmouth Hitchcock here. And utilizing the EMS medical directors at both of those institutions, as well as the EMS agencies that report to those medical resource hospitals, this will begin the network of the CREST for EMS network. These hospitals have the luxury of already being set up for much of the teleconferencing capabilities and educational opportunities that we look to roll out due to the establishment of the original CREST network. And so we've been able to tag along on all of the work that's been done for that and open up those resources to EMS providers at these regional hub hospitals. In the future, certainly the CREST for EMS network will look to expand to other regional hub hospitals to, again, incorporate those EMS agencies that respond to those closer hospitals. The second goal really is the development and the implementation of the knowledge and skills translational toolkit. Now, this is a combination of multiple different educational modalities that we look to roll out and offer to the EMS providers that will be responding and utilizing the central hospital ourselves, Dartmouth Hitchcock, as well as the 2 regional hub hospitals. We've identified and developed several targeted clinical topics and protocols within the 2 states that we will be utilizing and pushing through the process. Those include pain assessment and control, medication administration and correct route and dosing, splinting, spinal immobilization and restraint during transport, and airway and cardiac emergencies. With these 4 or so high-yield clinical areas, we will then be offering education in a variety of ways, targeting those. One of the things we will be offering, we will be developing and offering monthly case review conferences utilizing the technology network that was set up by the CREST network. It's a case-based format, really where providers can come together and discuss cases. This is certainly an important thing given the infrequent nature of pediatric emergencies and certainly significant pediatric emergencies in this area. So all providers in the associated with the 3 hub hospitals will have the ability to utilize and learn from those cases. We'll be developing and delivering quarterly didactic sessions, again, utilizing the technology network. So while the didactic session may be taking place live at Dartmouth Hitchcock, it will be streamed live to both of the other hub hospitals for all the EMS providers that would like to respond and to attend at the hub hospitals. The technological infrastructure is built there, so the high-speed networks are there. The cameras, the microphones, and the presentation equipment are all in place. Also, as an added benefit, the platform that we've gone with here to utilize this allows that really any provider from anywhere can access these events through their personal computer at home, through their tablet, through their cell phone. So the offerings of these educational opportunities will be hopefully much increased, and the availability and the accessibility for providers, no matter where they are throughout the state, is increased. The CREST for EMS network up here will also be holding an annual symposium focusing on pediatric pre-hospital emergencies that will allow us to access the simulation center here at Dartmouth, as well as cadaver and animal lab sessions and regular didactic sessions as well. One of the other large components of the knowledge and skills translational toolkit that we will be developing and rolling out is a simulation curriculum that will be working with a mobile simulation center that Dartmouth-Hitchcock will be acquiring. And so with the utilization of this mobile simulation center, as well as the development of a curriculum focusing on the high-yield clinical topics that we've already identified, we'll be bringing this to the local hub sites as well as agency centers to allow for that educational opportunity, which, while not necessarily very new in the field of medical education, is quite new for the pre-hospital providers up here that really don't have access to that type of educational opportunity. There will be an EMS-targeted website that will have educational entries, an educational blog, a podcast library, videos. All of the library and archived didactic sessions, case reviews will all be available up on the website as well. So providers in the surrounding areas will be able to access that asynchronously. And there will be also a question of the week service. While internet access up here is quite spotty in places, most people do have email and check it somewhat regularly. And so the ability to just pepper providers with tips and questions and especially pediatric EMS critiques, this will increase the frequency and their retention hopefully going forward. The third goal that we're looking to work on is the improvement in the communications and the relationships between pre-hospital and in-hospital providers and agencies. And what we're looking to do here is really develop a referral process through the CREST for EMS network and the hospitals that we will be working through to allow for the identification of particular topics that would be useful for PD pre-hospital education, as well as particular patients that would be perhaps able to take advantage of a new protocol up here that we kind of coined the exception protocol within New Hampshire. There is a protocol that is built that local providers at the paramedic level, under direction from online medical control and with a pre-written authorization and plan of action from the patient's primary care provider or subspecialty provider, they can administer life-saving medications in the pre-hospital realm that would normally fall out of their scope of practice. The best kind of example of this that we often use are the acalantide or the C1 esterase inhibitors for hereditary angioedema, that pre-hospital providers will be able to do this. And so what we hope to do is, we feel that this is being underutilized in our environments, and so make this exception protocol aware to all of the in-hospital pediatricians and subspecialists, so they can identify their pediatric patients that may benefit from it, talk with us, and then we can work with the individual providers as well as the individual EMS agencies with setting up these exception protocol mandated checklists so that can be taken advantage of in the pre-hospital realm. We also kind of are hoping to allow for targeted educational opportunities for these local EMS agencies for specific high-risk pediatric patients that may live in the communities. So again, with the rural nature, it's not uncommon that an EMS agency is aware that they have a high-risk, critically ill child that does live within their community, and they get called to quite frequently. It would certainly be nice to know the issues with that child, and with the permission of that child's parents, target education to that particular agency, dealing with the individual aspect of that child's medical care that they may be involved with in the future. And the last goal really is to develop and implement a competency assessment toolkit. This is hopefully a formalized and structured and evidence-based model of competency assessment developed to really assess the pediatric care of our local pre-hospital providers. we look to utilize kind of a newer thing in competency assessment, that global rating scale, which has been used in the past in other realms, but not necessarily very frequently in the pre-hospital realm, which is essentially a subjective Likert scale that is used by examiners for providers to assess their competency and their ability to do certain tasks. It's essentially will combine the global rating scale with the use of kind of traditional checklist evaluation tools that hopefully will allow for a better overall competency assessment. We again plan to use the mobile simulation center that we will be using for the educational side as well to implement and develop high-fidelity simulation-based mobile testing curriculum to utilize this global rating scale and the checklists to focus on the high-yield clinical topics that we'll be addressing throughout the 3 years. We'll be developing and deploying written computer-based testing as well for knowledge evaluation of these targeted clinical topics, and develop really a quality assessment program to kind of track some of the matrices to reflect true clinical care at the state level. So specifically, one of the things we're looking at is the use of pain medication in pre-hospital providers for pediatric patients. We will be tracking the use of this, the difference in the use and the correct use of pre-hospital pain medication for pediatric patients both before and after the educational interventions that are being performed. I'll be happy to take any questions regarding the project up here, as will Dr. Rohde.
Thank you, Dr. Tremarco and Dr. Rohde. A lot of exciting work, and here at HRSA we're seeing lots of exciting intersects that will reach out to you offline, but I think there's been a lot of work on the evidence-based pre-hospital protocols and a lot going on with the pain management. I think that will be published in pre-hospital emergency care in January, so hopefully that can be some guidance, and we're excited to hear about your use of simulation and competency assessment. Are there any questions? We have time for maybe one question for their team before we go to our next speaker. So I'm looking for either hands or unmute, or if anybody has anything in the chat box. Okay, well, thank you so much. That was fabulous. And again, we'll have Dr. Silverman.
Hi, Rob Silverman from North Shore LIJ. Next slide, please. So this is called the post-HAC study, or the pre-hospital steroid treatment of status asthmaticus in children. John Fries is the co-PI. John couldn't make it today. John was formerly the medical director for EMS, and now he's the director of pre-hospital research for New York City EMS. Also, as co-investigators is Doug Isaacs, who's deputy medical director and director of education for the department. John Averello is the chair of pediatric emergency medicine for North Shore LIJ Health System. George Fulton from NYU is a consultant. Charlie Schlein is our pulmonary consultant. And we have Dave Prezant from Special Operations, who's in charge of the World Trade Center project, and Glenn Asada, who's medical director for EMS, also as co-investigators. Next slide, please. So a quick background, everybody knows this. There are about 335,000 asthma-related pediatric hospital stays annually in the United States. Most asthma admissions to the hospital come from patients who are seen initially in the emergency department, and about 19 to 24% of patients seen in the ED for asthma end up being admitted to the hospital during that ED stay. This may turn out to be higher in our study because all of our patients will be coming in from ambulances, and therefore the patients might be sicker than some of this data that was quoted in the literature. Next slide, please. So, as everybody knows, steroids are the standard of care for treating acute asthma. There are multiple national and international guidelines which clearly state that oral steroids are preferable to IV steroids in children when treating acute asthma, provided that the child is able to tolerate PO. They're not vomiting or they're not obtunded. There is a CDC position paper, which was published in 2006, which describes a number of model pre-hospital treatment protocols, including those for asthma. And that particular protocol clearly states that oral steroids are the preferred treatment for treating acute asthma in the pre-hospital setting, provided that again, children not obtunded, and provided that that the child fails a single short-acting beta agonist. Early administration of steroids can reduce the need for ED pediatric hospitalizations. However, the administration of steroids is often delayed in the emergency department setting. There are a number of studies out there that show that when a child reaches the emergency department, if they do receive oral steroids or any type of steroids, the delay is often 1 to 2 hours. Therefore, by the time the child is ready to be hospitalized, the steroids haven't had a chance to, quote, kick in yet, and therefore the potential for preventing the hospitalization from the administration of steroids is not seen. It takes anywhere from about 3 to 4 hours for, quote, steroids to kick in, if they do kick in. Next slide, please. So our objectives the two main objectives are to implement treatment recommendations, the treatment recommendations from the CDC model protocol as well as from NIH and other international guidelines, by having paramedic providers administer oral prednisolone to children with moderate to severe asthma in the pre-hospital setting. And we want to determine the benefits of adding oral steroids to a treatment protocol in the same population. We're going to be looking at, quote, the value and worth of adding oral steroids to current asthma treatment in the pre-hospital setting, which currently includes basically just bronchodilators, including ipratropium and multiple treatments with albuterol, as well as IV magnesium in certain settings. Next slide, please. So the setting is New York City. Just as a quick background, the Fire Department of New York runs EMS, which is responsible for the operation of all units in the 911 system. The Fire Department operates about 70% of units in the city's 911 system, and the other 30% of 911 units are hospital-based, and a small fraction are run by volunteer organizations, but the majority are hospital-based. The Fire Department also maintains and controls emergency medicine dispatch, as I mentioned, telemetry, and other things, including mass casualty incidents in New York City. In the year 2012, there were 1.3 million dispatches by the 911 system in New York City, and about 15% of the call were pediatric. The population would include patients who are physically present in all 5 boroughs or counties of New York City. The 5 counties are Bronx, Brooklyn, Queens, Staten Island, and Manhattan. On any given day in New York City, including visitors and commuters, there's a population of about 12 million people. In terms of asthma calls, depending upon the year, there's about 30 to 40,000 asthma calls to FIDNY, and about 4,500 to 8,000, depending upon the year, are pediatric. So the design of this study is a prospective randomized trial, I guess you can call it, of adding oral prednisolone to current pediatric asthma treatment protocols. We're going to be doing block randomization by borough, so at any one time, half of ambulances will carry steroids, and half of ambulances won't carry steroids. When I say ambulances, I'm referring to ALS units that are staffed by paramedics. I think there are about 210 or 215 ALS tours daily in New York City. The paramedic ambulances will alternate carrying steroids. So they'll either carry steroids or they won't carry steroids. We're not going to have a placebo group in this study. And originally in the protocol, we were going to alternate every 2 weeks just to account for seasonal and temporal variability. But it got a little bit complicated, so we're probably going to change this to every 4 weeks. And that shouldn't impact at all the outcome, because the seasonal and temporal variation is not going to substantially it's not going to be different between 2 and 4 weeks. We hope to enroll about 600 patients over 18 months, 300 in the steroid group and 300 in the usual care group. Next slide, please. The inclusion criteria are kids between the age of 2 and 17 years, a known history of asthma, 2 or more nebulized treatments provided by paramedics, and will exclude children who require any type of ventilatory assistance, those who can't tolerate PO, those who have other lung diseases like CF, those who might have received steroids in the preceding 12 hours, and those who still have substantial respiratory distress after one short-acting beta agonist treatment. Next slide, please. The protocol, there'll be standard pre-hospital assessments by the paramedics. We'll be collecting the usual data, the usual sociodemographics, including age, gender, race. We'll have insurance status on record. We'll have all the usual time intervals, response and patient care intervals recorded. The electronic tablets, which just finally now are available to units in every borough, will include information on asthma, past medical history, current medications, allergies. We'll have a check-off for use of systemic steroids in the past 12 hours, number of ED visits and hospitalizations in the past year for asthma, the usual vital signs. We'll have pulse oximetry, hopefully initially on room air, repeated vital signs, and then we'll also have special checkoff boxes to allow the paramedic to communicate to us whether there's moderate to severe wheezing, moderate to severe work of breathing, moderate to severe duration of expiration to inspiration cycle, and any need for assisted ventilation. After the assessment, the nebulizer treatment will be administered to the child, and then the child will be reassessed. If there's a need for a second short-acting beta agonist and other protocol inclusion-exclusion criteria are met, then the paramedic who's carrying the drug will administer oral prednisolone 1 milligram per kg to a maximum of 60 milligrams, and this is going to be in a liquid preparation. Next slide, please. Outcomes. So the sample size was developed based upon hospitalization from the emergency department, but other clinical outcomes that we'll be looking at will be the length of stay in the EDs for those who are discharged from the emergency department, not hospitalized, ICU admission rates, hospital or ICU length of stay, and whether the children who received oral steroids in the field and went home from the emergency department were also more likely to be prescribed oral steroids from the ED provider on discharge. We'll also be looking at the frequencies of RMAs. Next slide, please. We'll be looking, as part of the demonstration and implementation portion of the protocol, we'll be looking at transport times, on-scene treatment times, EMS patient disposition, and the cost to the system of treatment, as well as projected system implications, additional resources needed for training and for maintaining the administration of oral steroids once the study is completed. Next slide, please. We'll be looking at barriers to oral steroid administration, including additional time needed, any potential interference of giving steroids with short-acting beta agonist usage. We'll look at factors such as patient refusal, child non-cooperation with taking the oral medication for whatever reasons, including the poor taste of the medication, whether the child is vomiting and that precludes the child from receiving the treatment, or whether the child's in respiratory distress and, in the paramedic's opinion, should not be receiving an oral medication in the field. We'll also be looking at outcomes including the training of paramedics, the time needed to train the paramedics in oral steroid usage, the cost for training, other resources for the training. We'll have standardized testing for paramedic evaluation, and we'll be looking at the need for retraining based on evaluation scores. Safety measures will include nauseousness and vomiting and any other adverse drug effects that we might not have accounted for, although the guidelines clearly state that there really are no absolute contraindications to receiving oral steroids, except if the patient's allergic to steroids or the patient is obtunded. After the EMS call, we'll be asking the paramedics, the ALS providers who take care of these children, to call in to telemetry for a post-call debriefing, where we'll be able to get some of the additional information that we require that I just mentioned, including the barriers to treatment and anything unusual that might have happened during the call. And that's about the study in a nutshell.
Thank you so much. I greatly appreciate it. We have time for maybe one question. I see Dr. Shaw. Would you like to ask a question?
Yes, hi. Manish Shaw from Baylor. I just have a question about the choice of steroid. There's some literature on use of either 1 or 2 dose PO dexamethasone having equal efficacy for treatment of acute asthma exacerbations, and there is some literature on decreased cost when using PO dex compared to 5 days of prednisolone. And our hospital is actually switching to this for ED use in our evidence-based practice guideline. And so I was wondering if you had considered using dexamethasone rather than prednisolone, since you could also use it for croup, since that's one-time dose administration for that disease entity as well.
That's a really good question. We had debated this when developing the protocol. And some were in favor of using dexamethasone. We ended up with prednisolone because it has the longest track record. It's most often recommended by the national and international guidelines, and we thought that we were going to have enough challenges getting this through the IRB without introducing a drug that didn't have as substantial a track record as the prednisolone. So that's the only reason that we chose the prednisolone. I do understand why one would choose dexamethasone, and maybe in a number of years from now that will be the gold standard. But since the efficacy appears to be similar, we felt comfortable with the prednisolone.
Great.
Okay, thanks.
We're going to move on to Dr. Stevens and Casey. And again, I apologize just to be cognizant of the time. If the speakers can kind of keep their talk to maybe about 10 to 12 minutes, we'll still be able to fit everybody in. So I will have the Indiana group take over.
Hi, everybody. This is Casey Allgood, Program Coordinator, presenting on behalf of my PI, Dr. Andrew Stevens, on the Treat the Streets Prehospital Pediatric Asthma Intervention Model to improve child health outcomes. Thanks for going to that one. Oh, yep, that's right, thank you. That's the right slide now. Our grant is allowing us to build and implement a new healthcare model using paramedics to perform in-home preventative and primary care for kids with asthma with the goals of reducing emergency care recidivism, improving pediatric health outcomes, and expanding the healthcare role and career paths of our medics. Our model will be integrated into the existing healthcare system, provides a bridge to existing health services, refers patients to the most appropriate venue for care, and supplements our traditional 911 services. There's a definite need for this healthcare model. Can you go to the next one, please? Healthy People 2020 has identified reduction of pediatric visits to emergency departments for asthma as a key objective. Additional pediatric asthma-related illness priorities include the reduction of hospital admissions, fewer missed school days, providing more families with formal asthma education, and improved access to appropriate asthma care. The economic burden of this chronic disease is substantial. The cost of inpatient care alone reaches $2 billion annually in direct medical expenditures. In one study of pediatric asthma admissions, over half of the affected children had government insurance as their payer source, suggesting that children in lower socioeconomic brackets are at particular risk. Between 10 to 30% of children admitted will require readmission following discharge, and studies have shown that ED recidivism rates as high as 25% within the month following an ED visit. Next, please. In Indianapolis, 15,000 children have asthma, and the rate of hospitalization for Indy kids is 2.5 times greater than the Healthy People objective. Nearly 60% of all asthma-related hospital stays in Indianapolis in 2009 were paid by publicly funded programs. The average cost of an asthma-related hospital stay in Indy was $13,500, up $3,000 from $10,500 in 2006. Next, please. The number of children living in poverty has increased in the last few years and this goes hand in hand with the reported increase in the number of individuals and families in Indy who need public assistance like SNAP and WIC. HRSA has identified 9 medically underserved areas and 26 health professional shortage areas for all disciplines within Indy. Our residents are at high risk of mortality, morbidity, and face challenges related to socioeconomic factors, the physical environment, health behaviors, and clinical care. Next, please. CMS, the Institute for Healthcare Improvement, and the Affordable Care Act all encourage the creation of healthcare models that improve patient care and reduce costs. They seek to reward and reimburse quality care, not the quantity of care. This pre-hospital pediatric asthma healthcare model is one solution to the increasing cost and changing demands on the healthcare system. In-home, post-discharge visits done within days of discharge will have the greatest impact on ED readmission and therefore ultimately hospital readmission. This enhanced EMS role will provide critical medical support for pediatric asthma patients, resulting in overall improved access to care, comprehensive home-based health assessments, and improved health outcomes. Next, please. Paramedics will provide in-home assessments of patients, disease management, environmental modifiable triggers, medical and social care needs, and referral to appropriate services. Faculty and staff at our partner institution, Riley Hospital for Children, will identify and route appropriate patients to our paramedic asthma care team. These patients may be high risk or referred by ED physicians, and they may be discharged from either the ED or an inpatient stay. As demonstrated by other in-home asthma care programs, these efforts should lead to healthier patients who better utilize the existing healthcare system and return to the hospital less frequently. Next, please. Over the last 3 months, we've hired and trained our paramedics. We're scheduled to begin our home visits in January, and by April, we want to visit 50% of pediatric asthma patients discharged from the Riley inpatient unit or the ED, and provide these patients with information on medication and disease management. By July of next year, we'll add a written asthma management plan to their care plan. In 2015, we will visit 70% of Riley inpatients diagnosed with asthma and 50% of Riley ED patients diagnosed with asthma. And in 2016, those percentages increased to 85% and 75% respectively. Next, please. We expect these visits to last for about an hour, and they will provide clinical assessment and medical interventions, medication reconciliation, environmental assessment, and referral to primary care physicians, housing and legal assistance, and other social need and specialty care, including the Riley High Risk Asthma Clinic and more. Next, please. None of these efforts would be possible without the assistance of our partners, including Indianapolis EMS, which is our affiliated 911 ambulance provider, which provides the EMS model, structure, and gives our medics plenty of traditional 911 experiences. The Marion County Public Health Department, Marion County is synonymous with Indianapolis, which provides some social work and in-home care training. The Regan Street Institute, which is our affiliated informatics and healthcare research organization. Riley, which provides us with a steady stream of patients. IU Health, which allows for the use of clinical time by IU faculty physicians. And the Indiana Health Information Exchange, which is a statewide clinical informatics network that captures data for IEMS and all of our affiliated hospitals. And it includes registration records, lab tests, and the UB92 records, which record the diagnosis, length of stay, and procedure codes for hospital admissions and ED visits. Supplemental paramedic asthma education and other resources are also provided by the Marion County Public Health Department, the IU Department of Pulmonary Medicine, Riley, and IEMS. Next, please. We will be using a lot of IEMS's existing tools and resources, including our EMTs and paramedics, a robust training and education division, affiliation with the IU School of Medicine, as well as Eskenazi Health, which is the county safety net hospital system, and a robust and shared electronic healthcare record and data collection management system, as well as our fleet service. These resources are vital to us reaching the goals of our grant. Next, please. We've got 5 goals. First is, and probably the most important, preventing ED and hospital readmission, improving healthcare access, developing our workforce, research, data analysis and dissemination, and sustainability. And I'm going to go into these goals in details over the next few slides. Next, please. The first goal is all about keeping kids and families healthy. We want to slow and prevent chronic disease, educate and empower patients and families, and decrease noncompliance and increase self-care. This should help prevent and reduce ED and inpatient recidivism and fulfills the goals of the new healthcare mandate. By January 2015, we expect our efforts will lead to a 20% reduction in the 30-day post-discharge readmission and ED revisit rate, and a 30% recidivism rate reduction by January 2016. Next, please. Paramedics will help identify and address the gap in the existing model of discharge care, remove barriers to effective treatment, and all this should decrease the healthcare costs for patients and providers. As I'm sure we're all aware, patients who receive appropriate, consistent health care have better outcomes than those who receive intermittent care in an inappropriate venue. We've already worked with our partners at Riley to ensure that their asthma clinic will be able to schedule 2 patients per week as needed and on short notice as referred by our medics. And next year, just prior to and during flu season, medics will incorporate flu vaccines into their home visits. Vaccines will be available to our asthma patients as well as their family members. Next, please. In addition to improved patient outcomes, this is also an opportunity for career advancement for some of our experienced paramedics. This month, all of our 1,500 pre-hospital care providers will receive continuing education on community paramedicine healthcare delivery models, which is also known as mobile integrated healthcare, as well as the Treat the Streets program. We have already created a curriculum to provide our community paramedics with continuing education in the form of classroom and clinical experiences related to all severities of pediatric asthma. Community paramedics will receive supplemental training from Riley Hospital ED, the High-Risk Asthma and Pulmonary Clinic, and pediatric and asthma-savvy social workers, pharmacists, physicians, and nurses. The initial training will be complete by the end of the year. Next, please. Paramedics are well positioned to direct patients to the most appropriate services at the time of need, services that often aren't a 911 response or transportation to the ED. Because of their existing experiences in patient homes and their role in the community, they are often already familiar with their patient population and their medical and social needs, as well as the community resources. Our medics will use this model to ensure that the right care is available to patients at the right time and right venue. For years, our crews have known what needed to be done for these patients. This model allows them the time and resources to do just that. They are patient advocates who are solving problems, helping families navigate the often complex healthcare system, serve as resource coordinators, and function as the eyes and ears of physicians. Next, please. In addition to the clinical work, we are collecting and organizing data for dissemination. Every fiscal year, we will complete pre- and post-training surveys on provider confidence and competency. By July next year, we will have a patient satisfaction survey in place. After a year's worth of in-home appointments, we will analyze data from the ED and hospital readmission rates and the associated changes in healthcare costs. We're also creating a pediatric asthma registry in REDCap, which we hope can be used to do some predictive modeling to try and determine which patients are most likely to readmit and then target those patients with additional care resources. And of course, we're looking to distribute this information via traditional academic methods, as well as social media, including well-established EMS and pediatric-specific podcasts and webinars. Next, please. We want our model to be sustainable long after the completion of the grant. We are looking to partner with other EMSC grantees, community programs, and healthcare providers to provide bundled services in community-based settings. Traditional revenue streams for the ambulance service may dry up as we eliminate the inappropriate use of 911 services and redirect care to appropriate venues. Our model should generate system-wide savings cost. We will approach some of our healthcare partners, whom we have saved money, and ask for part of the savings to continue to fund our work. We're also developing a model to bill payers directly for our services. Next, please. We'll be measuring a lot of things over the course of the grant. Success will be defined by reducing the quantity, frequency, and acuity of ED visits and admissions, the number of patients we serve, high and increasing levels of paramedic confidence and competency, patient satisfaction, the completeness of our data collection, the depth and breadth of our research dissemination, system-wide cost savings, and the identification, pursuit, and creation of a sustainable program and funds. Next, please. This is one of the few win-win type situations in life. Everyone benefits from this healthcare model. Patients and families, especially the socioeconomic disadvantaged individuals, taxpayers, payers like Medicare, Medicaid, and insurance companies, the ambulance service, and their staff. Next, please. I've listed out some resources here should anybody need them at a later time. Thanks so much for your attention. Last slide. Does anybody have any questions?
Again, we have time for maybe one question for Casey and Dr. Rohde. That amazing presentation. We look forward to your model of community paramedicine or integrated mobile health, as it's now called, in the pediatric setting. It'll be nice to be able to share that with others. Okay, just to keep us going on time, I'm going to have Dr. Manish Shah be our next presenter. Manish.
Hi, everyone. Next slide. So I'm going to share with you the Pediatric Evidence-Based Guidelines Assessment of EMS System Utilization in States, or PEGASUS project. Next slide. So the overall aim of this project is to improve the evidence base for prehospital care, and to do that, we're going to use the National Prehospital Evidence-Based Guideline Model Process to develop 4 pediatric relevant evidence-based guidelines on shock, spinal protection, airway management, and allergic reactions. Next slide. We have several focuses of this. One is the national focus to create these 4 guidelines, but locally we plan to implement, we're going to implement all 4 of them, but we'll implement 2 for the purposes of data collection in the Houston Fire Department to pilot test them, and then with those same 2, after some modifications and feedback received from providers, implement them on a region-wide level in all 6 New England states through collaboration with the New England Council on EMS. Next slide. So for AIM 1, we have established a guideline development committee. It's comprised of 4 pediatric emergency medicine physicians, 4 paramedics, 5 EMS medical directors, and 2 parents from a combination of Houston and all 6 New England states. We have had our first guideline development committee meeting where we have trained all of the members in the use of the Grades of Recommendation, Assessment, Development, and Evaluation Approach, or the GRADE approach to guideline development, and we'll then create the evidence-based guidelines on those 4 topics over the coming months. Next slide. As I mentioned, we will select 2 of them for implementation and study in the fire department. Though we have the buy-in of the medical directors to implement all 4, we'll just focus on 2 of them for the purposes of data collection and analysis. We'll also identify gaps in knowledge found from the evidence searches and use those to develop clinical research questions that could be proposed for subsequent study by other pediatric prehospital researchers, including the CHAMP node. And then we will evaluate the effectiveness of care and collect pilot data for subsequent testing of new therapies, and that will specifically be at the Houston site. Next slide. We will operationalize region-wide implementation in the 6 New England states through collaboration with the 6 state EMS medical directors and the EMS for Children State Partnership Program Managers in those states. Identify relevant EMS system and patient-level variables available from the NEMSIS database that we could use to evaluate structural process and outcomes measures before and after implementation, and then identify barriers or enables to implementation of the evidence-based guidelines, and we will be doing that through the use of social media such as Facebook, Twitter, and mobile apps with guideline information on it. Next slide. So this is just an overview of who's collaborating on this from each of the 6 states, Texas, and then one of our co-investigators is from Utah. I've also listed on there the state partnership program managers, since we've been in conversations with them about this project, and then we've also been in conversation with Tom Tremarco and Scott Rohde, since the guidelines that we're creating could have an impact on what they teach through CREST, and so we'll be in having quarterly conversations with the folks listed at the top of the page, since it would be important to keep them informed about the process of what we're doing. In the middle of the page, however, is listed the members of our Guideline Development Committee, and 2 of the medical directors on our committee are state EMS medical directors in the New England area. Next slide. So like I mentioned, we did have our first meeting several weeks ago in Boston, where we trained our Guideline Development Committee members on the grade process. We developed a list of clinically relevant questions to search the literature to develop these guidelines, and we are in the process of doing our evidence searches. Next slide. This is just a breakdown of how we've broken people up. You'll see that there is at least 1 pediatric emergency medicine physician, paramedic, and EMS physician on each work group. However, we will all come together again to discuss all of the guidelines, and so all 15 people will be part of the process for each guideline. Next slide. So between our first and our second meeting, our group has a lot of work to do. This is the week of December 16th, so December 7th. So we're all in the process of appraising the articles that our Evidence-Based Outcome Center at Texas Children's Hospital has found. We have conference calls roughly every 2 to 3 weeks between our first and second meeting, so that our group is prepared to present their evidence appraisals and their draft recommendations using the grade process at our next in-person meeting, which will happen at the end of February. Next slide. So at that meeting, the group will share their evidence summaries and draft recommendations with the group, and we will reach consensus on the recommendations, draft an algorithm for each guideline, and define any new questions that might have been omitted in the process the first time around. And then between the second and third meeting, we will seek out feedback from stakeholder organizations, including, but not limited to, the AAP, ASAP, NASEMSO, NAEMT, and NAEMSP. Next slide. And at our final meeting, we will review the stakeholder feedback that we've received, finalize the algorithm, and then select the guidelines that will be implemented for the purposes of data collection. And this is also the time when we will develop the list of study questions that I had mentioned previously, and then we'll also define a list of measures to study before and after guideline implementation. Next slide. Oh, that's it. Any questions?
Any questions for Dr. Shaw? Again, you can raise your hand or unmute or put a comment in the chat box at the bottom. Thank you, Manish. You have been busy. It sounds like a lot to accomplish, but you've got your group going, so we look forward to hearing the results. Next,
sure.
We'll move on to Dr. Fallett. I'm not sure if you've been able to sign on or not. Lindsay, is she available? We'll give them a second just to unmute.
Hello?
Hello, Dr. Fallett?
Yes.
Okay, we're having a
Can
little
you
bit.
hear me?
Now we can.
Okay. Okay. So the title of our project is called Compassionate Options for EMS. Do I have control?
There might be less background noise, Dr. Fallett.
Our team consists of...
You might need to turn off your telephone.
Okay. I have my phone on silent.
That's great. And I will be advancing your slides. This is Beth Edgerton, so if you could just stay next and I'll move the slides for you.
Okay. Is this better?
Much better.
Okay. So our team consists of besides myself, I'm a pediatric surgeon. Still having trouble? There's the air conditioner or the air vent is pretty loud in here. Are you still having a lot of background noise? Hello?
You're breaking up in and out, so I don't know if you can just stay close to the microphone so we can hear you.
Okay. Is this better?
Yes.
Okay. So Anita Barbie is a social scientist at the Kent School of Social Work at the University of Louisville. She'll be doing focus groups for us. Rick Forrest is a chaplain and works with our bereavement intervention program at Corsair Children's Hospital. Beth McClure is a research nurse. Peter Talek, whose name seems to be showing up in a lot of slides, is our co-investigator. Lindsay Goomer is administrative staff for us. Erin Calhoun is an intensivist who does a lot of simulation with the house officers. Erica Sutton is a general surgeon who works with Carrie Bonnard in the medical student simulation lab. And Lee Hagendorn will be helping us with the mobile app that we'll be developing. Next slide. So the overarching problem is that EMS providers are not well prepared to cope with the scene death of a child, and actually more children die out of hospital than in hospital. And so the goal of the program is to develop a system approach to out-of-hospital pediatric death that equips EMS providers with knowledge and skills to help families cope with next steps and also to understand how to provide self-help to themselves. And this is something that seems to be currently lacking from the curriculum. Next slide. This is a timeline that just shows the phases of the project, mine isn't showing up very well on here, but the first phase is the first 6 months, and during that time we'll be conducting both our family focus groups and our EMS focus groups. During phase 2, we'll be designing and developing a prototype for the mobile app that we'll be developing. During phase 3 will be validation of the mobile app using simulation and survey testing. And then during phase 4, we'll do field testing of the app both regionally and nationally with the hope of disseminating the information. Next slide. So during phase 1, which is the current 6 months, we've had 2 startup meetings once we were notified that we had actually received the grant. We pretty quickly were able to get IRB approval. We had most of those things in place. We were able to provide some information to the emergency medical services providers who attended our trauma symposium about the opportunity to participate in focus groups. Several people expressed an interest, and then this became or gave us the ability to organize several state focus groups that are in progress now. So we are, I think, just over the halfway point for enrollments. Many of these have been conducted. They've been well attended, and it seems that EMS is really interested in talking about this problem, vocalizing it, didn't work at the scene, and they also seem very interested to have the education and the resource developed. Most of the urban EMS providers we've already interviewed, we are going to journey to some of the places in the state where we have more rural services. Those are still being set up, and we're hoping at the same time to potentially be able to interview some family members then. So with respect to the family members, we have had what's called a bereavement intervention program at Corsair Children's Hospital for several years. This was actually the PhD project and his program. Any family who loses a child at the hospital is approached by Rick, and there we have resources that we offer to everyone, but we also have a tool that we use to decide who needs more intensive counseling or help in the bereavement process. And Rick then attends the funeral. He has a focus group with family members and friends to talk about the bereavement process and how to help the family. And it's a year-long process that includes several meetings with the family and just helping counsel their extended network about how to help them get through the process of bereavement. And so we have his database to help us identify families who either lost a child in the field or who lost a child in our emergency department, but we're looking specifically for families who had the acute death of a child. Let's see. And then we're also doing an evidence-based literature review just for current experience of field intervention after the death of a child to help with our app development. Next slide. So I think the process will help us identify the tools and support measures that we want to put into the app and develop this evidence base. Next slide. And this is phase one, which I've moved through pretty rapidly, but it shows just some of the dates for focus groups, and we hope to have that completed by the end of February, at which point we'll begin phase two. Next slide. So phase two will be our development of our mobile app, which will be based on expectation of how EMS will use the software. There'll be a number of things that will be included in the app, including some pre-recorded video clips, and then information for EMS about how to locate and maintain information regarding resources, coaching and discussions regarding self-care for themselves. And so the focus group results will inform this content as well as the literature review. Next slide. In phase three, which will be year two, we will test EMS using simulation. So we will train actors to be parents, and then we will recruit EMS providers in our state to be the subjects and to actually go through simulation exercises and to test the app to see for its usefulness. And then this will also allow us to provide revisions and updates to the app based on feedback. Next slide. We'll also then do some videos that we can take to both our in-state regional EMS conferences and to some of the national EMS meetings for validation before we do field testing in Kentucky, quality assurance, and further modifications to the app. And then simultaneously, we'll develop a curriculum that we hope will have some usefulness for EMS education ultimately, so that this is incorporated into EMS education nationally, so that it's information that is provided when they become paramedics and EMS providers. I think that's the last slide. Is there one more? And then that just shows the whole timeline. So there's like 3 minutes left.
You did very well, Dr. Follett. Are there any questions for Dr. Follett about her project? I have one question for you. Do you feel that there'll be some translational component for coping with also adult loss in the pre-hospital setting?
I absolutely think it will translate. You know, I can't see how it wouldn't be helpful. Many of the skills and communication skills are the same.
Great. I think that's you're filling a great need in that pre-hospital setting of not only self-care but just competency in handling those difficult situations. Again, I'd like to thank everybody for their time. The National Resource Center has supported our webinar today, so we appreciate that. And so that you know, at their website, they actually have a location for targeted issue topics where there's an archive of all previous targeted issue topics. We'll also be able to archive today's call, so if you have colleagues that would benefit from hearing about this, that will be available. We know a lot of our other grantees like to know what's going on with the targeted issue grants in the beginning versus when you all finish your project. So we're doing this early in the process. Well, I know you're maybe like, let us get to work, and but we wanted to have an overview of your project so that we could make some connections and partnerships that might be beneficial in you succeeding in your endeavors. Again, I appreciate everybody's time and effort in putting together your wonderful presentations. It's amazing the amount of work you've all accomplished in such a short time. Again, our contact information is here for you at HRSA, and I'm going to hand it over to Diane Pilkey for just a moment to give a little bit of an administrative follow-up on, I think, future calls regarding logistics of HRSA grants.
Yes, I think most of you have, who are grantees have received an invitation to a January 8th call, which will just be a call focusing on the grants management and the electronic handbook. And so the PIs don't necessarily have to be on it. It might be helpful, but if you're going to be involved with reporting and using the electronic handbooks and need to be aware of all the deadlines, that's what we're going to cover. And if there's specific questions you have that you want us to cover in this, you feel free to send them to me.
Great. Are there any last questions or comments from anyone on the webinar? Congratulations. We did it by 12:30. You guys are amazing. Thank you again for your time, and we look forward to hearing you again in the future. Thank you so much.